Welcome to today's Adults Health and Active Lifestyle Scrutiny Board. My name is Andrew Scopes, I'm a councillor for Beeson Holbeck and I'm the chair of this meeting. Just so everyone knows, this meeting is being webcast, so the recording can be watched live or later. You can put into any search engine the name of the Scrutiny Board and it will come up, at least that's my experience. But before we get on to any of the usual business, there's been some really tragic news. So since our last scrutiny meeting, one of our colleagues and councillors has passed away suddenly and sadly. And so at the start of the meeting, I'd like to just propose that we have a moment of silence and reflection, and then we'll get on to the formalities of the meeting. But I thought it was important to do that at the start. So if everyone can just stand with me for a little bit. Thank you very much. Councillor France Meir was, I'm not reading it, but Councillor France Meir was a valued member of the Scrutiny Board, and I felt like she always advocated for, in particular, things around foster care and care leavers, those marginalised and those excluded. So she'll be missed in the Scrutiny Board, but I hope her legacy will live on, and we'll remember the sort of challenges she would have brought to us and to the board. Okay. And it's a bit of a funny thing transitioning to a normal meeting in this sort of context, but I'm just going to try and do it. So I encourage you to come with me if that's okay. So we're going to start by introducing ourselves. As usual, make sure the microphone's close enough to you when you're speaking and turn your microphone off when you're not speaking. So we're going to start with board members, and then we'll come to other guests when we get to the relevant point, if that's okay. So as I said, I'm Andrew Scopes, I'm the chair of this committee, and I'm a councillor for Beeson Holbeck Ward, and we'll go to my left if that's all right. Thank you.
Good afternoon everybody, Councillor James Gibson, and I represent Crossgates and Winmore Ward.
Councillor Stephen Holroyd, Ardsley and Robin Hood Ward.
Good afternoon, Councillor Kevin Ritchie, and I'm Bramley and Stanley Ward.
Good afternoon, Councillor Bromley for Horsforth and Rawdon Ward.
Good afternoon, Councillor Taylor from Chapel Allerton Ward.
Good afternoon, I'm Jane Mashenko from Health Watch Leeds.
Good afternoon, Councillor David Blackburn, Farnley and Wortley Ward.
Good afternoon, Councillor Sandy Lay, Otley and Yeadon Ward.
Good afternoon, Councillor Lynn Buckley, Allwoodley Ward.
Councillor Caroline Anderson, I'm Adeline Wharfdale Ward.
And good afternoon, I'm Angela Brogden, the Principal Scrutiny Advisor.
Good, super, thank you, and welcome again to today's meeting. Angela, can you run through the first sort of usual items on the agenda, please?
Thank you, Chair. So in relation to item 1, just to confirm, there are no appeals against the refusal of inspection of documents. Under item 2, there are no items for exclusion of the public. In relation to item 3, there are no late items. And under item 4, at this point, please may I ask members to declare any interests in accordance with the Council's Code of Conduct. And I shall take silence as none. Thank you. And under item 5, apologies, Chair. All members are present, so we don't have any apologies. Thank you.
Thank you very much. We've had apologies from Councillor Emma Flint, who's the exec member who was going to be here today, but is unwell. But I understand officers are going to fill in what she was going to say. Super. I've got a thumbs up from down the table. Okay, so let's start with the minutes. Any points of accuracy on the minutes of the last meeting? I'll take silence as agreement. Good. And then matters arising. Anything from you, Angela?
No, Chair, none specifically, other than to confirm that obviously the composite report, the budget composite report, members had sight of and will be considered by Executive Board tomorrow.
Matters arising from any other members? No, okay, so we're going to move on to item 7, which I think is probably the main item today, which is tackling health inequalities. This is obviously a really important item and something the Council strives to do better all the time, and something that we need to do better at and keep our focus on. But let's start with introductions. So we'll start with introductions with Councillor Arif, and we'll go round the guests at the table. Thank you.
Thank you. Chair, my name is Councillor Salma Arif. I'm the Executive Member for Adult Social Care, Active Lifestyles and Culture. Thank you.
Good afternoon, everyone. Victoria Eaton, Director of Public Health for Leeds.
Good afternoon. Claire Turner, Chief Executive of Carers Leeds.
Good afternoon. Kate Daly, Head of Commissioning Adults and Health at Leeds City Council.
Hello, I'm Sarah Erskine, Head of Health Inequalities in Public Health.
Hi, Tim Fielding, Deputy Director of Public Health.
Afternoon, everybody. Magnus Harrison, I'm the Chief Medical Officer at Leeds Teaching Hospitals.
Good afternoon, I'm Ruth Burnett, Medical Director of Leeds Community Healthcare and Leeds GP Confederation.
Hi everybody, I'm Sophie Valanakis, Head of Health Equity at Leeds and York Partnership Trust.
Good afternoon, I'm Em Campbell, I'm Health Equity Lead at Leeds Community Healthcare.
Good afternoon, I'm Kash Sharma, Deputy Director, Adults and Health, Leeds City Council.
Good afternoon, Caroline Barrier, Director for Adults and Health, Leeds City Council.
Thank you very much and welcome to today's meeting. Can I just encourage you to bring your microphones a little bit closer and speak up so those of us a little bit more hard of hearing at this end can hear you. Those on the webcast can't see how big the table is, so it's quite hard without the microphones. So I think we're going to pass over to Victoria to start, and then if you pass on to all the people who are going to speak, and then we'll move on to questions. Thank you very much, Victoria.
Thank you, Chair. And like you say, Chair, Councillor Flinty isn't able to be here today, so I've got some comments which would reflect some of the points that she would want to make in introducing the item. There's just some brief headlines. I know we're really keen to get on to the discussion. So the first thing to say is that we're so delighted to share this report with you. It's an issue that's very close to our priorities for health across the city. The report sets out progress of how we're continuing to work to reduce health inequalities, and it follows on from a previous scrutiny session that we had with this board back in November 24, so just over a year ago. The report is comprehensive, as you can see. It describes a whole system and whole city approach, because that's how we look to address health inequalities across the city. There is particular focus on what's happening with the Marmot City programme, and there's also quite a lot of detail in there around the work of our public health team across the city. The report also highlights the role of the whole council, so we've included examples of what council colleagues are doing around the health inequalities agenda, and of course with our NHS colleagues who are with us today. I think it's a really critical point that when we brought this paper last time and when we answered questions last time and again today, we're doing this together with our NHS colleagues and partners because we know that this is the only way that we can drive down health inequalities together. We can't do it on our own. Our NHS colleagues can't do it on their own. So it's really important that we're here together answering questions around this work that we're all committed to together. The other thing to pull out in the introductory comments is around the content of the report around carers. We were specifically asked to include information around carers in the report, which is what we've done. And we have our colleagues here who are here to answer any questions on that particular issue. And just a last couple of points from me, that one of the things that we wanted to stress, and I think came out certainly in the last conversation we had and in the conversations leading up to this meeting today, is that we wanted to bring out in the report the decisions that we're making and the priorities that we're investing in as a city, making the most of finite resources. We have finite resources both in the NHS, across local government and in the third sector. So hopefully what the report shows is a highly targeted approach. And what we've got in there are some examples of work that's quite big scale. Some of our major public health services, for example, like our 0 to 19 service, and the contribution of some of our bigger services to reducing health inequalities. But you might also notice we've got some quite small things in there as well, very localised things that are happening in particular communities across the city. So there's a real mix of examples in there. It's not comprehensive. We would have it would have been a much bigger job to include absolutely everything we're doing across every single organisation around this agenda, but we've tried to bring out some examples of how we're making the best use of finite resource to make the most impact on outcomes on this agenda. And then the last thing I'll draw out is that we've tried to include a combination of whole city work that we've signed up to at scale, with actually very local work that's been driven with our local communities. So one size doesn't fit all, and we've got some examples of how we're trying to balance the needs of our different communities around this agenda as well in the paper. So I'll leave it there, Chair. Thank you, and I think I'm passing on to Ruth. Am I? Thank you.
Thanks, Victoria. So, in my various roles, so I chair the newly established Leeds Health Inequalities Oversight Group, which we've put quite a focus on in the paper following the meeting in November last year, which I wasn't present at. That was one of our key aims. That group has brought together the three trusts, primary care and the ICB, with some really key advisors and public health to pull together the providers in Leeds of healthcare to really ensure that we coordinate, challenge ourselves and prioritise the areas of focus that we can achieve better together. I've tried to include within the paper some of the key areas that we have focused on this year, with the group coordinating, but also balance that with the work that each of the individual providers has done within their own sort of establishments and their own fora, and how that work coordinates us to enable us to look at things better together, because we know that inequalities are impacted even more greatly as patients transfer along pathways. So I've tried to balance, like Victoria, the whole city picture, the work that we've done together, and the individual areas of focus. Similarly, we're looking at ways that we can drive a whole city approach, but make sure the data enables us to target most carefully the communities or the areas where inequalities are having the greatest impact, and shape how we drive those changes and how we are better able to work with those areas.
Thank you. Did Kate or Claire want to comment at this point? No, you don't have to. Okay. Right. I think we're going to move to questions now. So if members want to ask a question about this paper, and as I've said before, you can find the papers if you're watching by putting in Adults Health Active Lifestyles Scrutiny Board Leeds, and they'll come up. I can see Councillor Blackburn, so you can go first. Anyone else, please indicate, and I'll bring you in.
Thanks. Basically, just a quickie here. You've got a number of things where it's GP recorded physical things, mental health and etc. And then it refers to them per ward. We were discussing this at our community committee group, which I sit on a while back, and what I'm not clear on anyway is how do these figures relate to the ward we live in, or the ward the GP practices in? And I'll give you a good example. I live in Farnley and Wortley, and I go to a GP practice in Pudsey. My wife lives with me, obviously, and she goes to a GP practice in Armley. And we've been sit with the same GP practice since we've been young, and that's why we stuck with them. And we're not that far away. And if you look around my ward, a lot of people live in my ward don't actually use the GP practices that are there. So how do we manage to get these figures together, and are they accurate about people who live in ward?
Chair, do you want me to take that? Yes, Councillor, yeah, it's a really good question. They're based on where people live. So they're based on home postcodes, home addresses, regardless of where they go to the practice. So they should be a reflection of those areas rather than irrespective of where you are at your GP. Thanks.
Thank you. Okay, Jane, next.
Thank you. I have a few comments and questions. First of all, it's fantastic to see such a really comprehensive report, so thank you for that. And it's really good to see the commitment in terms of the strategic partnerships and the programmes across the board. One specific technical question, I guess, is within the report it talks about being able to look at the healthy life expectancy, and you're using national data for that rather than local data. And I'm just wondering, could we have local data in the future? Is that feasible? Because that would be really useful. I'm thinking about the neighbourhood health community teams as they get established, how valuable that would be as an impact measure going forward. So that's a kind of technical question, I guess. One thing I noticed that I found a little bit shocking was the rise in temporary housing accommodation, and particularly for those with children. I just wondered what was happening in relation to that. In terms of the healthcare partnership, again, really great to see this commitment by all our main providers. I just wanted to mention a couple of things. One is a little bit of concern, so hopefully you'll be able to reassure me that we're going through this transitional year where we've got really significant governance changes, where the provider partnership is going to be taking on that kind of whole system approach and holding a grip on these kind of things. But it's not established yet. But meanwhile, the Leeds committee is reducing in capacity. So my fear is that these kinds of quality and inequality agenda will kind of get lost in that. So just needing a bit of assurance. And then in relation to that, I also just wanted to mention, from a Health Watch perspective, a key thing to remember in terms of inequalities are two things: digital inclusion, and it's kind of the core business really, digital inclusion and accessible information. So just remembering that, when patients have sensory impairment, so they can't hear, they can't see, just to communicate with them appropriately. Make sure you don't rely on digital when for everybody. There will be some that just cannot use digital means. So that was mainly around that. Now just one final thing, and that is relating to the carers report. So really important to see this report. Thank you for including it. And the one thing that made me a little bit worried within that was the acknowledgement that it's difficult to identify young carers. I'm just wondering what's happening in relation to that.
Thank you ever so much. There's obviously lots there. I'm not going to attempt to answer all those, but if I just comment on some of those specific ones, and I can take the first one very specifically, which was your question about healthy life expectancy. So, yeah, absolutely. The healthy life expectancy is really, really important because it does show that other side of life expectancy, and it shows how long actually and relatively people spend in states of poor health and those huge inequalities. At the time we put this together, which obviously wasn't that long ago, the only information that we had or still have is at a national level. The reason for that is that the measures, the way they measure what state of health people are in, is taken from a national survey that they do, and it simply isn't done at a local enough level for us to be able to use that. So we're able to calculate all our own local life expectancy, which we can then do by age, and all of that's within our gift. We don't have the ability to do that for healthy life expectancy because we simply don't have the measures to replicate that locally. However, we have been querying with the ONS just off the back of preparing this report whether there's any plans, because there's often been some talk of doing more at a local level, and literally just in the last few days we've had a response from the ONS to say there are plans to produce some localised data for healthy life expectancy, hopefully coming in the summer. So that should be done at MSOA level. So MSOA level, I think off the top of my head, is about 3,000 to 4,000 households. So you have several MSOAs that will make up, say, a ward. That will hopefully be available. We're yet to see it. What that should give us is an indication of the extent of that slope of inequality within local authorities. We'll have to see what that looks like when it comes as to how useful that is, how much we can break that down. But watch this space, and there will be more coming in with luck. Just say very quickly on the others. Others might be able to comment more. The temporary housing, the reason we've put it in there, I mean, you're referring to the Marmot indicators that we've included in there. And I think just to say for a moment about what the intention of those are, when we started doing the Marmot work, obviously the Marmot work, as people will well know, is about the social determinants of health. It's about the 80% of things that make people healthy or not, and drive inequalities that aren't to do with health care. And so it's across the full breadth of those social determinants, and there wasn't anywhere we felt that actually brought together a high-level set of indicators that identified what progress we were making as a city, but critically highlighted the level of inequality within those indicators. And that's the gap that we've tried to fill with the Marmot indicators. So having those proxy, high-level, sort of 14, 15 indicators that spread across the breadth of the social determinant work. Households in temporary accommodation is a really key one, as you say, that it does give that indication of what's happening in relation to housing, and we do see that really concerning trend. It is one that's been widely recognised in the council, and there's been some cross-council and cross-city work that's been held, and summits specifically to look at this and to try and understand and explore. And I know it's very much part, for example, within the council, is one of the key priorities around the cross-council prevention work that's featuring as part of the council plan and aligned with the Leeds ambitions. But yeah, others might want to say more on that. I'll let others comment on the things like the NHS transitional year, but just to say it's something from a broader system point of view and around health inequalities that we're certainly closely engaged and involved in that partnership, and working alongside and through some of those developing structures, as you talk about, like the provider partnership and things, and will be very key to wanting to make sure that these items and these agendas around health inequalities play in, and also these papers for people's awareness that have come today are also on the agenda tomorrow for the Leeds, the ICB and Leeds committee, where we'll be having a similar but different conversation, because it will be focused around some more of those particular issues about the implications of this agenda, I imagine, around that coming sort of transitional year as well. But others may want to pick up on some of those.
Thanks, Jane. So in response to the observation about the NHS transitional year, which is a description I quite like, actually, I think it's a fair challenge, and one we're conscious of, and I think that's the key thing, is that we need to be and remain very actively conscious of it. The advantage of the oversight group, as it has been established, is that it is it is run by the providers together with public health, and with really key attendance from Health Watch, Forum Central, some of the inclusion groups, and primary care. So to a degree, we hold each other to account for keeping that group running, for keeping those priorities running. There might be some uncertainty about where it sits in the governance going forward because we don't know what that governance looks like, but together we are massively advocating for its place in that, and we've had the opportunity to feed into the Provider Alliance review and things as a group.
If I could come in on question, Jane, that you've raised around digital inclusion and accessible information. We absolutely are very mindful that we comply with the accessible information standard, that information that is printed and provided in written format is mindful of visual impairment and people's needs, and digital inclusion doesn't mean exclusion. It means making sure that we are supporting people to access information in whatever format works for them, and that it's not exclusively on a digital basis. We still have absolutely processes in place to share information by telephone, by visits if necessary, people coming in to our different bases and spaces, our family hubs, our community hubs, so that they can access information in that way as well, in person as well. So we're really minded around our legislative and statutory duties around accessible information standard. In terms of the Carers report, if you don't mind, I'm going to hand over to Claire from Carers Leeds to say a little bit more.
Yeah, I think on care identification, I mean, it's really at the heart of what we are trying to do at Carers Leeds and our colleagues in Family Action who work with young carers, and trying to identify people early is a massive challenge. You know, we know there's really good evidence to say that, you know, for adults, it takes people about 2 years to self-identify. So I think when it comes to identifying young carers, I think a huge part of that work is engaging with schools and colleges. It's like, where are young people at? Who is best placed to identify them as a carer? So I think Family Action have got a really good scheme that's trying to encourage organisations to become young carer friendly. And I think that applies as much to sort of services working with adults. So if you're going into somebody's home or you're working with families, then actually there are a whole range of people that are really, really well placed to spot an unpaid young carer. But certainly I think schools and colleges are a massive priority, I know, for our colleagues at Family Action.
Any follow-up, Jane? Oh, Victoria, can I just, before you come in, Victoria, can I just push back on, are the academies engaging?
I think, as you can imagine, it's mixed. There's a mixed picture. I think we do have the school census now, and there is a question in there about young carers, but I think we're still seeing schools that say, well, we don't have any young carers in our school population, which we know can't be actually true. So yeah, I think there is work to do. But certainly I think we've got some, again, my colleagues in Family Action will be better placed to talk about the detail of that, but certainly some good examples of where schools and colleges have been engaging well, but certainly more work to do.
Thank you, Chair. It was just to make a brief additional point on Jane's comment around the changes in the NHS and how we keep focused on this agenda through all of that change. I think it's a really important point that you make, as well as all the other ones as well. I really support all of the points, including the one around digital inclusion and accessible information. Absolutely. But the point about the changes that we're seeing, particularly in across the whole of our NHS partners, and how this affects our work around health inequalities, is something really important that we need to keep a focus on, because the work that we include in the paper today, you know, I think we can all say we're incredibly proud of how far we've got on this agenda, even though there's still huge challenges and a long way to go. But we've got here through the commitment and dedication of people who work locally in the system in the city. And actually, in the next year, we're seeing our Leeds ICB obviously have a bigger footprint around West Yorkshire. and be a smaller organisation with less connection with communities. So I think there's a real job for us to make sure that we still have a very close connection with and understanding of our communities. Leeds is a big enough place to do that at scale. It's very hard to do that on a bigger geography. And the council also plays a huge part in scrutinising and advocating for our local Leeds population within the new arrangement. So I think there's a huge amount of work to do as the ICB is there is a year of transition, but the ICB changes are already starting to happen and we're seeing those working through. We need to make sure we build the local arrangements that actually have this wired into the very centre of the approach, because we know if we don't do that, by default, actually inequalities worsen. So I think it's a really pertinent point around how we keep this approach going over the change that we're seeing starting now. Thanks, Jane. Thank you.
Yeah, super. Thanks for those responses. I think that's really interesting on the whole conversation. I think really interesting on the academy. So it might be helpful to send some further information to us, and then we can consider as a board of any actions we can do to support that conversation. Okay, I'm going to bring in Councillor Gibson next. Thank you.
Thank you, Chair. A similar sort of question to Jane, really. I'm coming at it from a slightly different angle, really, because I mean, I think we should be. Well, thank you on behalf of the board, actually, for everything that you do. Firstly, because I think we're recognised nationally as a sort of leader in everything, in our strategy, in everything that we do to try and tackle health inequalities. And my question sort of stems from that, which is, now that health inequalities is at the heart of the changes of that we're seeing within the wider NHS, and I'm specifically talking about the 10-year health plan. Will that affect the way that we go about our business? And you've Jane's already sort of touched on this, but there isn't any money that I can see for public health. There wasn't anything referenced in the medium-term planning framework, or and certainly obviously nothing in the 10-year health plan. And of course, on top of that as well, we're still waiting to see what the government direction is for adult social care, so with the Casey review. So with all that put together, emphasis on, we're doing a great job, there's an emphasis on health inequalities in the 10-year health plan, but there's not necessarily any more money for it. What is the plan for us as a city? I do have another question about Marmot and big housing developments, which I always ask when we get to scrutiny, but I'll wait for this question to be asked first. Thanks.
I'll start on that, and if the colleagues want to add, they may want to come in. Thank you, Councillor Gibson. I think, I mean, briefly in response to your question, I think if you look at the 10-year health plan, and constituent parts of it, like neighbourhood health, it's a very broad brush approach to how that might be interpreted locally. So what it isn't is a very detailed action plan for actually how local areas should take forward those 3 shifts and also the neighbourhood health work. So I think what we're seeing is very, very broad plans nationally that we will have to interpret locally to actually develop our models. So with neighbourhood health, for example, the guidance nationally is still incredibly broad. It's quite NHS focused. We want to develop locally a much broader approach around more community services being involved, more preventative services and things that keep people healthy, kind of as part of that model. We expect we're never going to get that direction nationally, but in a way it's a license to build it locally. So I think that what we do will still be down ultimately to local leadership. Which is not a bad thing, because we've got some great people in this room, but it does make it up to us because it's not wired in anywhere to the system. So I think that's absolutely where we are. Thank you.
Is there anything you want to say on social care, on just with Casey, and we're just sort of in limbo with this? You know, what got any ideas about what we're doing, future planning?
Thank you very much, Councillor Gibson. We are in a little bit of limbo with regards to the Casey review. Certainly we're taking up every opportunity to feed into the review around the implications for adult social care going forward in terms of reform and the need for reform. At this moment, it's a little bit silent on any feedback on the outcomes of the discussions that the Casey review team, Dame Louise Casey herself or the reviewing team have come up with. We are anticipating some sort of outcome from the review in this financial year, the 26-27 financial year, pending final outputs from, I think it's April 2028. But so far, we keep feeding information into the system to say, how are these reforms, social care reforms, going to impact on our ability to meet needs of our local residents at a time when our demographic pressures show increased demand, ageing populations, more people living with multiple health conditions. And at this moment in time, it is absolutely silent. We hope that what it will mean is an even stronger emphasis and resources allocated to ensure we can meet the needs of our local residents currently and in the future.
So turning now to, we touched on Marmot earlier, and us being a Marmot city. I know the emphasis is on children's rather than adults, but we've had conversations before. I've had private meetings, and I've raised it at this committee. There is a lot of house building going on in the city. In my ward, for example, there's roughly 5,500 houses being built. Next to, adjacent to where the houses are being built is an area of the city that sits in the lowest 10th percentile nationally for deprivation. And it seems to me an obvious opportunity that if we're building new houses with lots of new infrastructure, including access to a wonderful new bridle path and country parks, that there should be conversations about how new development would help tackle health inequalities within existing communities that are perhaps deprived. You know, there's obvious opportunities around public transport, active travel, access to green spaces, access to new GP surgeries, new schools. And I was shocked the other day that I had a meeting about a GP surgery. It was sort of changing their catchment area, if you like, for want of a better phrase. And I'd mentioned that there was need for a new GP surgery, and there was plans for a new GP surgery in my ward as part of the new development. And they were kind of, and this was representatives from the ICB. They were aware, and there were conversations happening, but they weren't all over it in a way that I expected, and asked me for contacts for our development team within the council. So it was for me to sort of link people up and put them in contact. They were a great team from the ICB, by the way. They were lovely. They couldn't be more helpful. But they weren't all over the detail in terms of the extent of the development and the opportunities, potential opportunities. So it feels like the opportunities are falling through the gaps because we're working in silos. That the NHS is not linked in enough to our, the housing development team and developers and our traffic management team and our, sustainability team or whatever it might be, and that surely the Marmot team or a team, from public health that's working on this sort of agenda should be the linchpin at the centre of this, making sure that we're pulling everybody in the right direction and making the right decisions for that communities. And it doesn't feel like that's happening in my ward, and there's a lot of anger about it, quite frankly. There's a lot of anger from local residents in my area, and I feel frustrated as well because, if it's a lot of disruption to build so many houses, but that's fine if there is going to be positive outcomes for the local communities that are being affected by that disruption. And unfortunately, they don't seem to feel that there are going to be positive outcomes. And I can't convey that there are because it doesn't feel joined up enough.
Yeah, thanks, Councillor. And I know, having obviously had discussions with you, how passionately you feel about this, and I completely agree with the points that you make. I think it is an area that there's a lot more to do. I think there is some good work happening. Spatial planning, which I think is what we're talking about in its broadest sense, and that sort of healthy place making is absolutely something that there's an ambition there to do and join up. The Marmot stuff itself, I think, is one of the routes to do that, and I definitely think we've got a role to play in terms of how we contribute that. One of the things that we have done significantly over the last few years is close those gaps between public health and regeneration, certainly, and we have a much closer working relationship now in all sorts of ways that we're working more closely. In a moment, if I could give Sarah a chance to talk about some of the work that we're doing, for example, which is mentioned in the report, but would be really good just to hear about, for example, piloting the health equity assessment tool in the Heart of Holbeck work, which is a really substantial development where we're really working in a way we've never done before to try and embed a much more systematic assessment around opportunities to both close, but to make sure we don't increase inequalities in big regeneration projects like that. But that isn't, we're not doing that systematically everywhere. So I think there's more scope to do that. I think areas where we do link up are through, we have a whole range of input across public health more broadly into things like the local plan, and are very, very closely engaged with planning department in terms of informing and shaping the local plan, which ultimately is what does shape those local structures. But I would absolutely agree that I think there's room for improvement. In terms of the wider involvement around the NHS, again, I think that's fair comment. Some of that I think happens well, some of that I think that there's room for improvement over existing structures. I think some of the neighbourhood health stuff is giving a good platform and shaping some of that and improving it, but I do think it's got a way to go.
Before you come in and talk about Holbeck, great that it's happening in Holbeck, and I'm sure there's some fantastic work going on there. The East Leeds Extension is one of the biggest development projects in the country.
Yep.
5,500 houses next to a road that is the East Leeds Orbital Road, and if you've never been along it, I would encourage everybody to go along it. The bridleway there, the pocket parks, the country parks, it's wonderful. It's a great amenity for the local, for everyone in East Leeds. It's fantastic. If we're going to do Marmot stuff, surely now's the time to do it with such a big project.
Yeah, absolutely agree. And I think with that's completely our ambition, and the basis that we're working with regeneration colleagues is to get absolutely as upstream as possible and working at the very earliest stage in terms of those plans that are coming down the pipeline, those spatial plans, to make sure that we design in those issues from the very beginning. But
sorry, I'm going to come in now because I think it's a really important thing to come in on. So I think you're right, that's good in terms of future plans. And I guess the question is, what about this current project, which we've missed the earlier stage, I guess is the thing. And then added to that, I guess, in terms of for us as Scrutiny Board, who's responsible for improving things in the future? Is that the public health team, ultimately, or the Marmot team? And I don't mean to be really aggressive, I just mean to help us be scrutinised. Thank you.
Thank you. Can I come in on that point, Councillor Scopes? Because I think this is a really interesting and helpful conversation, and I think gets to the sort of nub of probably where we are. So back in the beginning, just over 2 years ago, when we agreed to be a Marmot City, we had conversations about where we wanted to put our efforts, and obviously housing and health was top of the list. The other priority was 0 to 5s. Interestingly, the housing priority was predominantly driven by elected members, and the 0 to 5 priority was predominantly driven by NHS colleagues. And that I think reflected the prominence of this agenda. So we really get that this is a big deal and continues to be a big deal. I think, as Tim said, what we've got are some early signs of progress in the way that we work together across a council and a city in which these connections hadn't historically been made and work hadn't historically happened together. So I think, as Tim's described, we've got some areas where we've started to do that, but the next phase is clearly to scale that up to be more systematic, so we can say we're doing it where we need to, if not everywhere. So, and that one of the challenges 2 years into the Marmot work was around this scale up, join up and be bold. So this is a brilliant example which is really helpful to us, and we can take that back into our conversations across the council and with housing colleagues to say, actually, we've had this very helpful challenge from this conversation today around that not just happening in pockets, but that happening more systematically. So we agree with the comments, and it's really helpful because we do know we need to move into that next phase of Marmot where we stop testing things and start actually putting them in more systematically. So I just wanted to say thank you, Councillor Gibson. I know this is not fixed for now, but it's helpful in order for us to take it forward. Thank you.
And just to answer the question, I think specifically about accountability and responsibility, I don't want to sound like I'm sitting on the fence, but I think it has to equally be to ourselves. I think we need to absolutely be accountable for being proactive, forthright and engaged, and making the capacity to do that. And equally, colleagues on regeneration side and others in the council need to equally be accountable for the way in which projects are planned, brought forward, developed to actually do that in that inclusive way. But I think one example, if that's okay, Chair, I think would be really illustrative.
Well, Tim and Victoria have covered a lot of what I was going to say, but I think just to respond directly to the East Leeds work, we are now at the point, I think, with trialling, which was one of the recommendations in the Marmot City report. So these things take time to kind of work themselves through. We're at the point now with the health equity assessment tool and the Heart of Holbeck work where I think both regeneration colleagues, local partners and people in public health would say that it's actually working and it is having an impact. So we could, as Victoria says, now have a conversation about how we might use some of that learning or even the heat tool in the East Leeds orbital work. The tool itself is quite rigid, but we've been able to apply it in a very sort of flexible and creative way through the Heart of Holbeck work. So I'm sure we can think about at what stage we kind of join the tool and the East Leeds work up together. So, but yeah, lots and lots of work going on. Often things aren't badged as Marmot, but there's lots of things going on in the background around joining up the housing workforce, the health workforce, through training, through linking up and developing models around the kind of selective licensing, private rented sector work. So lots of things going on in the background which may not appear to be Marmot, but are having a kind of policy and an impact on how people work together. But I'm really interested in thinking about the East Leeds orbital work and the health equity assessment tool going forward.
Thank you. So one of my questions linked to that, so I'm going to jump in here. So there's the current planning review underway, which is going to be out for consultation soon. I guess the question is, are we, as in public health, are you feeding into that? And I guess linked to that is, are there any statistics? So if you look at page 20 and 21 of the pack, paragraph 4.17 talks about some of the challenges, including physical inactivity. So any stats you can put in there or recommend? For example, I guess one of my concerns is building loads more houses in the inner city where there's already not enough green space. So is there any stats you can say which is essential, like how much green space per person is there? You can't go beyond this. Do you know, that sort of thing that just puts something a bit more rigid? So I guess, are you feeding into it, and have you got some stuff to put in there?
In short, yes. So, and I think this is a really good example of where the work we do isn't solely, so the Marmot gives us a broad framework and helps us go further faster, but actually I wouldn't take the credit through any Marmot programme in terms of the way we feed in, because that's a long-standing relationship that public health have had, and we actually have a Healthy Places bit of function that sits under our Healthy Lifestyles team, and they work very, very closely with planning in terms of the actual planning application process and feed in. So we're very much part of it and do work very closely with them. But that was already well established, and feed in really informs the very specific policies that are in there around informing whether it be around hot food takeaways or whether it be around physical activity data, and whether it's about feeding in local demographic health outcome data from local areas to inform that, and that feeds in very, very closely to the local plan process. So yeah, very, very close, and equally other regulatory functions, so licensing, others, and we're quite well advanced in Leeds in terms of the way we work with those regulatory functions.
Thank you. Okay, I'm going to bring in Councillor Ritchie next, please.
Thank you, Chair. Just some comments on the report, first of all. I really welcome it, particularly the joined-up approach, bringing in all the different partners. I think that's really important. And I think it was Dr. Burnett who actually mentioned the third sector challenge within the NHS, which I think is really important. I just hope that that doesn't get stale, as it can when you get to know people and build friendly relationships. So hopefully that'll go on. And just to, again, also to reflect on the use of equity throughout as well, which is so important, isn't it, as well? So a great report. I have actually got 7 points. Shall I just go through them? Yeah. So on page 26, when it's talking about the public health grant, I'm intrigued that Leeds has got the lowest allocation in the core cities, with Nottingham the highest. Is there any evidence from Nottingham about the difference that makes, that extra funding, in terms of some of the stats, whether it's this, the health programme, stop smoking, breastfeeding, so that we can then go to government and show, I'm sure we're always asking for more money, but with sort of the evidence base, look, Nottingham have done this, can we do that? So that's the first question. The second is around planning. It's more of a comment. Councillor Gibson's covered it well, and it's actually on page 31, and you reference the work, excellent work that you've done around trying to influence planning applications. And I just want to reflect on one that's mentioned, the McDonald's, or the drive-thrus in Stanley Ward and Seacroft. And public health officers did a fantastic job in the Stanley objection. And it shows actually the fact that officers recommended approval and didn't give it enough weight to that report is very disappointing. But actually worse than that for me, and I did say this in my objection, is that members, elected members, who sit on scrutiny boards, whether it's this one, Children's, have been health champions, and I've sat with some who were on that plans panel, and we've all agreed, and it's been cross-party, about these sort of developments are not good for public health, and yet they voted to approve it. Very disappointing, but thank you for your work on that. On to page 33. And the vaccines. I've raised before my concerns over vaccine hesitancy, and often linked to conspiracy theories and what have you. I just wondered if there were any stats available on the people who were admitted to hospital with, say, flu. What percentage were actually vaccinated? So if 90% were unvaccinated, that's quite a powerful message to get out to people, and perhaps try and challenge some of the vaccine hesitancy. So that's that one. 39 now, I'm on to, just bear with me. Yes. Now, it may just be me. This is the chart around it says the decile chart. I don't know if you can go to it, but I can't really understand what it's telling me. This is the only chart that doesn't seem to be. It's around ethnicity, I believe, and I don't really understand what the numbers are telling me at all. It's the only chart that I can't follow. So an explanation on that. It's on page 39, that one. So I'm getting there. If you. And then on to page 47, this is around the, this is around education, and I'm interested in the difference between, this is educational attainment, Pakistani and Indian young people, why we think there's such a difference really, because they're from a similar part of the world, of course. Perhaps it's linked to poverty within the different communities, but that did strike me as quite a significant difference. And then on to page 49 on the NEET. So slightly concerned to see Bramley and Stanley Ward at the head of the NEETs table. I do recall when doing my weekly surgery, we used to have a team based in Bramley working on NEETs, and our third sector partner Barker also had a programme. I'm not sure if they're still operating, but I wondered if we are going to be targeting more resources in the wards that are higher, but is it perhaps that we've done really well in turning not knowns into NEETs that maybe accounts for some of the higher figures? And the very last point is around the carers report, and I note on page 79 there's a line that says, excuse me, in Leeds, all agencies working with adults and children have a responsibility to identify any young person who lives with someone in their household with a caring need. And it just struck me as a school governor, and again this might be a weakness on my part which I'll look to rectify. I don't think I've ever asked a question around carers at school, and we get lots of stats, care leavers and so on and so forth, send a big focus on attendance, but it's never been on the agenda to identify children who may be carers. So again, is that something that we can make as sort of a statutory obligation of governing bodies to see the number of carers in their schools? So quite a lot there, but hopefully you can work your way through them. Thank you.
Okay, I'm going to make a start, and I'm sure colleagues will jump in. The first one about the public health grant funding. Thank you, Councillor, for all your comments and questions. Yeah, I mean, if Councillor Flint was here, I'm sure she'd say something about it, because she's very interested in the ongoing issue of why we're relatively poorly funded compared to our neighbours and other core cities, and it is an issue that we're actively still addressing. Interestingly, if you look at the outcomes for Nottingham, which is at the top of the funding per head list, and we're obviously at the bottom of that funding per head, there's not a neat track of, well, they do much better on everything because they get nearly twice as much as money for public health. And I think that's mainly for maybe two big reasons, partly because we've lived with a low level of funding now for public health in Leeds for such a long time, ever since we came over in 2013 and even before that when we were still in the NHS. And in a way, we've kind of found very creative ways to work around it. So we actually had a higher level of additional transfers of funding from our ICB, our NHS colleagues, to make up for the low level of grants. So that did compensate, but we had to be locally creative and make that happen. And I think the other point I'd make is that spending the grant that we get directly from government on public health interventions is a very important part of what we do. But actually, another way of working is to influence the whole council, the whole budget of the council and the whole budget of the city in more of an influencing way. So I think we've always, because we've had quite a low grant, we've always done more of that. So yeah, it's not so neat to see in those. But having said that, we know we benchmark low on our spend on some of our big services, and then we know if we actually did have more grant, we'd be able to put more investment into those services, which should lead to better outcomes. So there is an issue around better outcomes, but it's not so clear, and we've found different ways to work, I think I'd say, around that. Just on a couple of others, you mentioned around the vaccine hesitancy issue, Councillor Ritchie. I mean, it was very complex with flu this year. I don't know whether my colleagues from the NHS want to come in. It was very complex with flu this year because we had a really early flu season, and one of the strains was kind of not, it didn't play out as we thought. And the flu vaccine only ever gives us a certain percentage of protection. It's not like MMR where it's more clear cut. If you have the vaccine, you really won't get the diseases. So it's always a little bit more nuance with flu. So unless, I mean, colleagues may want to come in, but we did, the good news is we did see a really good take up this year from groups who were eligible. I think a lot of the stories around it's a terrible flu season actually made the uptake. It was helpful for us in terms of getting a very high uptake in the groups that we wanted. So the uptake was very, very positive this year. I think that it's much clearer cut for something like measles. When we have a measles outbreak and people are admitted, that's almost exclusively non-vaccinated children, because it's this very clear-cut sort of cause and effect with the vaccine. So we do generally see it in outbreaks that people who are admitted to hospital are highly likely to be unvaccinated. So that is a message that we use with vaccine hesitancy. We continue to, in our work around vaccine uptake, promote action around misinformation, disinformation, because we know that this is rife in social media and other channels, so that's still a priority for us. However, the one, I think I've said it here before, the main reason for people not getting vaccinated is poor access to vaccination. So all the work, I'm sitting next to Councillor Arif here, all the work that we did in COVID around actually taking vaccines to where people are and how they live their lives, helps much more, as well as the work we do around hesitancy. So we'll continue to work on both. I can come in on some other stuff. The only thing I'd say around the data, I'll let colleagues come in on the data, but the difference in ethnicity around those groups, even though they're geographically close to each other in country of heritage, is a close association with poverty. But that's the big driver there. But I'll let colleagues come in on those. Thank you.
Could I just come back on the vaccination issue? So I think the vaccine hesitancy that you described, we see. The flu season, as Victoria's described, was early this year, so the vaccinations would have had to predate that by about 2 weeks. And it's really difficult to actually tie in a positive test result with a pre-hospital vaccination that we have no knowledge of. Mm-hmm. From an admission rate, those who are over 85, the rate of admission in over 85s, irrespective of vaccination or not, is higher than any other group, unsurprisingly, I'd have to say. Thank you.
And is that because you've got separate data, or the data about who's had the vaccine is separate to your data? Okay.
Okay, I'll attempt to try and come in and comment on some of the other questions, Councillor Ritchie. Just to follow up where Victoria left off, also just to really emphasise that issue about, you particularly identified there people of Indian heritage versus Pakistani and the differences. Absolutely echo what Victoria said there about there being very significant deprivation differences in terms of those groups. But and I wouldn't pretend to be an expert and be able to explain all the reasons for that. But I think the key thing is we do see that trend. I think it's a well-established difference where you do see that through a lot of different indicators. It's not just educational achievement that you see substantial differences between those two populations. And I think really the sort of takeaway for me for that is the absolute point and purpose that we've done these marmot indicators is to really be able to shine a light and say with all these indicators, we're not claiming with these marmot indicators overall that we're in any way now responsible for them or we've got the answers. This is about a structural tool that we're trying to make sure is in place in our system, in our council, in the city, to ensure that actually these key sort of sentinel indicators, we've got a clear line of sight on them, but not only on the average level, but critically on those, the breakdown by inequality. And I think it just shows the importance to make sure that we're keeping an eye on that sight, keeping a line of sight on that difference, seeing whether that changes and reduces ideally, but also making sure we take into account those differences in terms of the planning and all the sort of partners, colleagues across the council, the city are doing. We're responsible for that. And I think that the same would sort of follow through really with the point around NEETs. Again, so it's a really important indicator about 16, 17-year-olds not being in education, employment or training. There's unquestionably a range of work on it. Clearly that will sit predominantly between children and families and employment and skills in that, and I absolutely know and I'm involved in a range of work and focus and a lot of discussion on this. The real point of this is to keep that line of sight on that inequality, and one of the fundamental principles about trying to address inequalities at all, but certainly through the Marmot work, is that sense of proportional universalism. So recognising, and I think there's a couple of things I'd highlight from that chart by wards. Firstly, is there's no area of the city this doesn't affect. Every area of the city has some element of children that are not in employment or education or training. So it is a citywide issue, it is universal, but it is far from equal, and there is a very clear inequality there that means we need to proportionately focus all that attention absolutely on those areas most in order to try and reduce that. And I think that's the key intention of these charts, to inform and shape whether it's other scrutiny committees, whether it's other areas of service, to really be trying to be driven by this. There was one other question which I'm afraid I didn't quite catch. You said you had a question about interpreting. I thought you said slide 39, page 39, but looking at the papers and you said it was around ethnicity. I'm afraid I can't see anything about ethnicity, so I don't know if you just want to advise which page that was, and I'll try and answer the question.
I think it is 39 of the pack. The slide on the right, I think is what the one Councillor Ritchie was referring to.
Do you mind, sorry, Chair, do you mind just saying what the title of the slide is, and I'll try and...
It says, the right-hand chart looks through the alternative lens where possible, this is of ethnicity.
And it's the title of the chart overall?
Well, it doesn't have a doesn't have a title. It's
It says what are the charts showing?
Right, thank you. Sorry, my apologies. So what we've tried to do in this is, thank you. So I think it's the one that's a sort of guide one about what they're trying to do. What we've tried to do is illustrate how the rest of the charts are structured and the best way of reading them. So it's a guide one. So the one on the left is just identifying the fact that we've predominantly broken them down by deprivation decile, and we've tried to show on the right hand that basically we've tried wherever possible to first and foremost break down the indicators by deprivation decile. That's the main chart generally on the left of each of the indicators, and then we've tried to say that on the right we've tried to select a different disaggregation or a different form of inequality as appropriate to the indicator and which one's best. So in some cases we've done that by ward where appropriate, in some cases we've done that by ethnicity. I hope that answers the question, but that's just the way we've tried to present it to give a clearer view as possible.
So is this slide showing an example? It's an example slide. It's not actual data, because I'd assumed it was how diverse each ward is as actual data, and so maybe I'm reading it wrong.
Yeah, no. So the page 39. Page 39 is just basically trying to illustrate how to read the charts going forward. So the actual charts themselves start on page. The first one of the actual charts themselves is on page 42 and is male life expectancy at birth. And that's the first one where you get the charts with the actual data themselves, and then they follow through.
Okay, so it's a little bit interesting, maybe ironic's not the right word, but the only chart that Councillor Ritchie couldn't understand was the one that's meant to help him understand the other charts.
We've clearly failed in our attempt to make that clear.
So maybe it wasn't quite as helpful as you'd hoped. I say that in the best nature. Do you have any follow-up questions on that, Councillor Ritchie?
Not really, other than just what is it saying then? Harsley and Robin Hood at 493, Headingley and Hyde Park at 2,100. What's it actually saying? And the only other question I haven't been answered is around the carers question on schools. But thank you up to date for all those really helpful questions and answers rather.
Yeah, I'll take the carers one. So already, as I said on the paper, that Leeds has adopted the No Wrong Doors for Young Carers memorandum. So I think in a school context, it's worth asking, because that places the responsibility in all agencies working with adults and young people to identify young carers. So I think in a school context, it'd be really important to ask whether the school has signed up to that. And also, as I said previously, I think the school census is also a really good tool, because that's the vehicle through which schools should be collecting data on young carers at school. So I think asking for that data, and also the process for collecting that data, how do we know? So I think those two things are really, really strong tools already that we already have to support identification of young carers. So I think it's about making sure that agencies are using those.
Okay, I think I need to just hold my hand up and say I think you've probably just caught us out there, Councillor Ritchie. I think basically this chart has been included to try and explain. I think those numbers have probably been left in error from a previous one, so they're not actually directly indicated. They could be to do with some other... I mean, I can find out, but it's not really relevant. I think they've been left in by error when that chart's been put together. The point that we were trying to get across is that you will see you'll see this broken down by, for example, ward, or on the left, for example, by demographic. So we are about to update these slides anyway, because we've just got the new IMD data out and the new data. So I'll take that back and make sure that when this is updated, those figures are taken out to avoid confusion going forward. So appreciate that. As ever, you've had an eye for the detail. Thank you, Councillor.
Thank you very much. Okay, I'm going to bring in Councillor Anderson next.
Thank you, Chair. I just wanted to touch on inequality and access to GPs. So in the Outer North East Community Committee, I chair the Adults in Health subgroup, and at a meeting last month of a small group of councillors, concern was raised about people not having access in villages like Bardsey and Scholes. And what's been happening is the people that live in Scholes have been told that their GP surgery is going to close and they'll have to go to Crossgates. So going from Scholes to Crossgates is not easy if you don't have public transport. Now, it's fine saying not everybody in every small village in Britain can have easy access to a GP, but these GPs were there when these people moved to the village, and now it's going to be taken away. So what is happening around equal access to GP provision, please?
Yeah, I mean, it's not something strictly that I would say comes under our sort of programme of work. That there are other areas of health inequality work being specifically done around primary care. So there is a grouping of practices, GP practices, that are looking at that, and it would be something that would more come under the issue of the ICB. I think it's probably fair to say, in terms of ICB planning around access to it. I don't know, Victoria
I'm
might
just
want
going to come in here. So we've actually got access to primary care in our March meeting, but I do take the point it is relevant to equality of health because access to GP is an important item, and so maybe that's something to think about in the future. But I take your point; it's not in this report. Unless Victoria has something to say, you can comment if you want.
Thank you, Chair. Well, I mean, only to note that it's come up a couple of times today already. Councillor Gibson mentioned it before, and Jane mentioned it in terms of the health changes. So I think that when not for today, but it is a critical issue about the impact of the changes in the NHS and what they will mean for key issues like this for us locally. Obviously, it is a responsibility of the ICB. We have a Leeds ICB. At the moment, we'll have a West Yorkshire ICB going forward. So I think it's something that we can definitely pull out of that conversation next time. Thank you.
Yeah, and I think the point is valid around it is an element of the wider health inequality piece. I guess maybe it being a West Yorkshire-wide ICB will mean there's more rural areas, and so maybe it'll be a bigger deal for West Yorkshire ICB than a Leeds ICB, but I don't know. But public health will be at the next meeting, so really appreciate your input on that specific question next time. Is that okay, Councillor Anderson? Okay, so Councillor Bromley next.
Thank you, Chair. And yeah, thank you for bringing this report really detailed, and thank you for all your work. I really welcomed your report on heat in Leeds and ongoing work with that. In terms of some of the things that were identified during that engagement, were discussions around the fact that 30% of residents in Leeds live in flats, and also the concerns around access to green spaces or areas outside that also have shade. So I just wondering how going forward you envisage us looking at this and incorporating it in a Marmot style of these services. I can see on 5.18 there's a multi-agency group that has come together to build stronger relationships between the housing staff to develop a citywide model. I just wondered, is that something that may then look at, say, if somebody needs air conditioning in a high-rise flat, would that fall on the NHS to be funding, or is that looking at the local authority to be shouldering? And also, when it comes to access to green spaces outside, would that be something that would then be in partnership with, say, Pro, that we know that under constraints of budgets is often quite constrained for their flexibility in what they can do, and also bringing in third sector organisations, community organisations that also would normally support work with that, so that we are embedding multi-agency that also works on a very community level when it comes to heat and Leeds with this as well. Thank you.
Thank you, Councillor Bromley. I think what's happening with the recommendations of the current Director of Public Health annual report around heat in the city is connected to the commitment to health inequalities in this paper. So maybe we've not brought it out as much as we could do, but there's definitely a huge amount of work in taking those recommendations forward. And at the centre of that work is a commitment to reducing health inequalities. So we will absolutely join that up, and happy to bring that back at any time. I think there's focus on some quite tangible things through the recommendations of that report. So, for example, one of the recommendations was around ensuring we develop a network of cool spaces to support people who need to use them in the hotter months in the way that we've developed warm spaces through the colder months. So there's very active work across the council and the city around that cool space development and green space development. And also work, again, it's with housing colleagues around really thinking around people who are most at risk in the housing that they live in, which might be south-facing high-rise or other properties that have got poor heat insulation, around how we start to engage housing colleagues on this agenda. So obviously it's some of that's quite ambitious and will take some time. But yeah, just to assure you that that's all going on, and we're joining that up with this as much as possible, and I'm happy to provide more information on that if that's helpful. Thank you.
Yeah, thanks. And I guess just to add to that from a slightly broader health and housing perspective as well, the first thing I'd say is I think the greatest benefit of all of this, and the greatest impact and the most powerful outcome we can have through all this health inequalities work, is how we systematically embed these processes into the way we operate as a council, as partners, and as a system. And so for all the individual sort of projects that we're doing, it has to follow through to projects, but that's why doing things like piloting the health equity assessment tool process, having reporting and data that fundamentally tracks and identifies inequalities at its core as a matter of course, both in the council, across the system, and through healthcare providers, is absolutely essential, because it puts an absolute line of sight, and it means we should be considering these things as first principles. So I think getting those things in place and having the increased evidence from things like the DPH report should mean that they are systematically taken into account in decisions going forward. So I guess that's the first one, and I think is always the challenge we need to make. You asked specifically about the group that's referred to, the multidisciplinary group. That group won't be doing the sort of thing you're talking about, because that's been brought together very specifically around predominantly practitioners, and actually off the back of the selective licensing work that's happened in the city, to really try and, in the theme of the Marmot work about joining up and scaling up and being bold, to really take and seize those opportunities. This was at the time under the previous scheme, and if there were to be a new scheme, would continue to really bring together, close the gaps between the housing workforce and the health workforce, where then they weren't aware of each other, the opportunities, and working closely enough, and the opportunities presented by things like the selective licensing to really operationalise those and make a real difference on the ground for people. That was the purpose of that particular group, and the joint training that was linked to it and associated. What we do have, however, is a broader health and housing group, which is chaired by elected member. That's where there is some of that broader conversation, and there is opportunity and scope to think about the broader projects and impacts a bit more widely around health and housing, and where we could be looking at some of those broader schemes as well, and opportunities. And the last thing I'd say is, just to give you some assurance, we try and take a really broad view, and it is one of the things that we're really ambitious about, is the whole health and housing work. I mean, I've literally just this morning been having an hour's introductory meeting with the new Chief Officer for Housing, who's going to be coming in shortly, talking exactly about this, how we work really closely, the level of ambition that we've got, where some of those gaps still exist, how we can close that, but also going back to the earlier conversations, how we do that also including in a three-way with regeneration, who've got a critical part to play. So we need to work absolutely seamlessly between the three of us in terms of that broad health and housing, around the spatial planning, the pipeline around development of housing, the management of housing that they do in Housing Leeds, the homeless work, the private rental sector work, and ourselves from a health point of view as well. So hopefully that gives you some assurance about the way those issues play into that system.
Thank you. Just to add on to it as a comment, really, more that sometimes we struggle with our housing stock just on getting on top of repairs, never mind an added element that will come with climate change. So I think my emphasis is more that like, where might new funding come from to help with that. But I think it would be really helpful to look into and understand more on the health housing group, and then if we could have this back again, that would be really helpful in my opinion. Thank you.
Thank you, Councillor Bromley, and I can see Angela's typing away, so your point will be noted. Councillor Lay is the last person on my list. If you want to speak, he's not the last on my list now, but if you want to speak and you haven't spoken, please indicate now.
Thanks, Chair. Let's move that closer so people can hear me. Thank you all for coming. I'm going to waffle a bit, but I'll try not to waffle. All right. So the purpose of this meeting really goes back to a previous board meeting where we asked for these themes. And I notice in the brief summary it talks about us wanting to see evidence of outcomes or progress on outcomes. I might be missing something here, but I'm struggling to see evidence of outcomes in comparison to anything. There's a slight page 39, which is now infamous, Councillor Ritchie, does have deprivation and under 16s as a comparison with national or with England, but I can't see any comparisons really around how we've progressed, other than broad themes around we're better at breastfeeding, we're better at respiratory mortality, we're better at, but we're worse or static on activity, activity in older life, obesity, diabetes, cardiovascular disease, but I can't see any progress. I have no data on to look back and say, well, in 2012, when I came onto this board in its previous iteration, this is what we were doing as a city. And in 2025, I'm not suggesting I want 13 years worth of evidence, but much of what we're talking about now seems to be exactly what we were talking about 14 years ago or 13 years ago. Life expectancy is still 12 to 9 years, depending on where you live, worse than in the best areas. I think you call it healthy life. It's 20 years difference. And so there are lots and lots of people living with comorbidities and long-term conditions that are, what I say, alive, but not living. You know, I can't see any evidence where it shows me that we're making improvements. Other concerns I had, or not concerns, but I wanted to ask about the waiting list initiative. The report also says in the first paragraph, I think, of Appendix 2, that 80% of inequalities are created by non-healthcare issues. So all the things we've talked about, housing and lack of etc. And that there is a waiting list initiative in pilot regarding, rather than taking just clinical priority, and as everybody in this room knows, I'm a healthcare professional, so I understand how important clinical priority is, but rather than just taking clinical priority, we're trialling other inequality determinants to perhaps move people who have less health equality up the list. Is that my understanding of this scheme? How's it going? Are we expecting it to expand? Is it doing well? It's quite a small pilot by the looks of things. Healthcare is enormous, healthcare is complex, healthcare is expensive. Are we looking to expand it? And my last real question in all of my ramblings there is, I'm just trying to find where it is. Let me find it. My third question was, I can't find my third question, but that's pretty much what I wanted to say.
Thank you, Councillor Ray. And it's interesting because I was thinking about your point about the progression. We do get the performance reports, but that doesn't give you it gives you since the last metric rather than an ongoing what's our last 5 years. And I accept that I've been away for 3 months because I've been unwell, and you may have had a progress report, but this report isn't it, because it just gives me a snapshot of where we are rather than are we forward or backwards. And we've had previous charts that show green arrows, amber, red, that's the performance report, yeah, which isn't here. But Victoria, do you want to comment on the point? But I think it'll be worth Angela sending you the performance report, but it doesn't give you like the last 13 years for sure anyway.
Yeah, do you want me to? I'll come in briefly and then I'll hand over to Tim, who might want to add a little bit more. So You're absolutely right. We do bring every 6 months a detailed performance report on a kind of a whole suite of indicators to this meeting, and there's some technical appendices to that which do go back for most of the indicators several years. 10 years for most of those indicators, so we've got the 10-year trend on those. I think what we wanted to do, and that came to the last meeting of this in January, so yeah, we were mindful this was coming straight after that, so we didn't want to duplicate all the data. I think what we've tried to do is lift some headlines from that data to give a summary. And like you say, Councillor Lay, in section 4.6, 4.16, what we've tried to do is highlight some of the things that actually have been going more positively over the last few years about specific indicators of health inequality. So there is still some good news in amongst the challenge. But you're right, it's not a comprehensive summary because we've got that in the normal performance report. So yeah, I think definitely that was the thinking. And with this report, wanted to get on much more to the, so what are we doing about it, rather than describing the problem. But yeah, more than happy to share the performance report. And where possible on the commentary on that performance report, we I know we've had lots of conversations over the sessions here, but we always try to comment on the long-term trend as well as the most recent change in data. So there is more of a picture of over the long term, this is getting worse, better, staying the same. So more than happy to have another conversation about that, but it's what we've tried to do with that report. But Tim, did you want to add anything?
Can I just say that that's all very true, but it quite clearly says in our brief summary that we asked for this theme, this report, to bring. The latest update would include a focus around addressing inequalities in NHS Leeds, the impacts of cost improvement programmes, and the support across health and care. It also, where is it?
So Councillor Lay, I think you've made your point, and you've had an explanation which you're not necessarily satisfied
I'm happy with. I'm happy with, but it just says and progress on outcomes.
I accept your point. Tim, do you want to come in on Councillor Lay's other comment?
Thanks, Chair. I mean, I think it's really healthy to constantly have that challenge about outcomes and the progress on it, and we do take that really seriously. We have tried certainly to give the sort of progress. A lot of that is activity progress, and we do constantly keep challenging ourselves about where and how we can do that. Just to say, the Marmot indicator set, which we've just been referring to quite a bit, that's included at the end of appendices 1, sort of page 39 onwards, they are a snapshot of a given year, but one of the developments of that as we update them is how we use them then, because they were just developed. That's the first cut of those, about how we use them to try and show movement and how they change from one period to the next, and that's part of the next development of those. I won't reiterate what's been said about the performance report, because obviously that's been well made. What I would just say is what we did try and do, and it was very much informed by the conversation at the last one of these committees when we discussed the performance report, and I think, if I'm not mistaken, it was a question from Jane that was around, no, it might not have been Jane actually, sorry, it might have been another colleague, which was around life expectancy, and that similar point to say, almost basically, does any of this make a difference? Because actually we always come back and say we've got this gap in life expectancy that remains fairly consistent. And it was a really useful reflection, and that's very much driven the sort of slightly expanded discussion that we've included on life expectancy that's on from sort of page 18 onwards, where I really wanted to draw out this isn't a given, and this isn't fixed, and this isn't static. And actually what hopefully figure 1 shows is those trends overall in life expectancy do change over time. The gap changes over time. And actually these are really amenable to policy changes and differences that we can make, particularly obviously at a national level, but also locally. So things we do change and make a difference in these, even though they might not feel like they change much period to period or year to year, because it's only marginal amounts. When you look at the trend over the last, say, 20 years, you can see some really quite marked differences there in the way that life expectancy was increasing steadily for 10 years. then it really plateaued and levelled off, and actually that inequality grew substantially in that same period, but has just started to close in recent periods as well. So I do think we should really see that as a call to action, that these can be affected and they're not just static. I don't know whether other colleagues will be able to talk about the waiting list or anything else.
Yeah, really happy to take the waiting list question. So we were using something called a HEART tool, the Health Equity and Right to Treatment tool, which was developed at University Hospitals of Covent and Warwick. Sadly, it was on an access database, so it was quite difficult to, I don't know who last had an access database. We had to link an access database to our data within the trust, which proved difficult. And you're absolutely right, we picked a fairly narrow patient group in that it was upper limb surgery at Chapel Allerton. What we did realise was that it was absolutely essential that we did this throughout the whole of our waiting list. So we're developing a tool internally so that when we look at the clinical urgency, length of time waited, we'll also have visibility of the deprivation index as well for that particular patient. And this is all really quite uncomfortable for the NHS because we're used to doing priority 1, priority 2, and we go through a clinical triage. So it may be that when we get to priority 3 and we're looking at major indices of deprivation, we do not want to take that in a clinical priority way. We want to do it in a completely different style. P1 and P2, there's no difference. They're clinically urgent cases that need intervention within prescribed timeframes. There's no discrepancy there. It's when we get to P3 and P4 patient groups that we see the biggest discrepancy. So yeah, completely agree with you. It's an ongoing internal discussion, and we will have all our waiting list with visibility of deprivation index. Just to say though that the most important visit is the first visit when referred to an outpatient appointment, and if people miss the first visit and we end up having another year wait, and some of our waits for first appointments are not insignificant, it's that one that we need to focus on. As soon as we get people in, the sooner we get them seen and an intervention planned, the better for all.
I should place on record that I don't think we're doing a bad job. I think I read somewhere recently that the latest indices of multiple deprivation are showing that many of our communities are moving up and out of the 10%, but I can't remember where I saw it or whether I dreamed it, but I'm sure I did see it somewhere. But they're not public yet, is that right? Or they're not widely public, because I did have a look the other day to see if I could find them and couldn't find them.
I thought they were the bottom 1% neighbourhoods. Yeah, that's right. But I don't know if they're widely public. Yeah, Tim?
Yes, I'm just trying to find. We have got a reference to it in. So yeah, the indices of multiple deprivation have been updated. The ones we've previously used and the ones that much of this data is still based on was IMD 2019. So that has just been updated, and so we now have a new IMD 2025. Which is here. So in Appendix 1, 4.18 talks about the change to the index of multiple deprivation. And as it says, the recent IMD reporting has indicated that there's been a shift to a lower level of deprivation in Leeds when compared to other areas. However, it's not possible to state that absolute deprivation is reducing because the measurement of deprivation in IMD 25 is different to that used in 2019. So I think the thing to bear in mind is these are sort of their point in time measures of relative deprivation, and the way they've calculated the 25 one is quite substantially different in many ways to the way they counted it in 19. So it isn't really a measure of how places have changed over time. It's a measure of how places rank across each other at that point in time. So yes, in practice we've got less areas now, or fewer areas that fall into IMD 1, so the most deprived areas, and there's different ways of interpreting that, but I would suggest some caution in suggesting that means those areas have categorically changed or changed in any absolute measure. But happy to talk about that more outside if that's useful. But,
sorry. So I'm not right to congratulate you on moving people out because you're saying it could just be the change of the way they measure it.
So I guess it's relative to the rest of the country, isn't it? And so it's a statistical phenomenon, is what he's saying. So if we are no longer in the, if our community is no longer in the bottom 1%, it could be that our community stayed flat and others have got worse. And that's what he's saying. It's just a statistical, he's trying to explain a statistical phenomenon.
Well, that don't help me. I like things simple. Are things improving? Are things worse? Are things static?
And that's not you can't answer that simply, can you? Because there's too many factors and there's too many different ways of measuring things. I think that's just a and he's trying to explain the data. And I think Councillor Taylor, you're last now. Thank you.
I don't know where to go, Chair, because Councillor Gibson have asked my question, and I've written down nearly everything what you said. But my question is, we are talking about health inequality, and health inequality is a platform of different issues. So what I'm asking is, for you to come and tell us that who you working with? Are you working with the police, private landlords? What's the other one that I put down now? The schools, planning, businesses, because they're all collective together. I've got a high list of deprived housing where my residents are in disgusting house, and that comes under you. So as Councillor Lay says, the report is absolutely brilliant. It's a good read. I've read it 1.5 times. It's good, but the things what I want to see in there, it's not in there that this is what I'm doing. I would like you to come and say to us, I am working with the police to do that, I'm working with landlords to do that. You go in my area, so it's council, it's a very deprived area, and it's 1 takeaway, 2 takeaways, 3 takeaways. Those are the issues that comes with me with health inequalities. It goes down. You have high blood pressure, it tick you off. The patient don't go back because it's down and they don't know if it's go back. So you are taking this report based on what happened last week. Where are the work happening and who you working with to complete health inequality?
Thank you, Councillor Taylor. No, I welcome your comment, and I guess in answering the question in a very succinct way, yes is the answer to those partners that we would be working with. We are working with. Now, have we captured all of that in this report? No, I don't think we have, and we may need to. So, for example, the work that we do around drug and alcohol harm and preventing drug and alcohol harm across the city is highly done in partnership with our colleagues in the criminal justice system. Both our prisons, Young Offenders Institute, the Offender Health Probation Service, etc., as well as police colleagues, third sector. Now, obviously, that's a whole agenda in itself, and because this is about the 80% of the way people live their lives, which makes the difference around whether we reduce health inequalities or not, essentially. I think what we're wanting to get across is that, and what Tim's stressed throughout, is this should be kind of cutting through everything we do across the whole of the city, across the whole of the council. That's the only way we're going to shift this. So it's about systematic, comprehensive work with housing, with regeneration, with economic growth, with our private sector colleagues. So we need to, in order to really shift these outcomes in a significant way and in a sustainable way, we absolutely have to do much more to make this everybody's business. So this is the job of course this is my job as Director of Public Health, and it's the job of the Public Health team to really lead some of that work across systems. But we can't do this as a Public Health Department in a council. We'll never make any impact. We can only do this if we engage all of our colleagues in all of our sectors, and actually that's long-term difficult work. I think we're making loads of progress, and we actually do work hand in glove with all of the sectors that you suggest. But are we maximising every single opportunity there? Not yet. We've still got a way to go on this. So I think I'll leave it there, Chair. But I think I take the challenge of Councillor Taylor's point. But I guess that there is something about we might want a deeper dive into some particular areas that shows what that relationship is with critical partners. We might want to do some of that. And more than happy to look at particular themes alongside the overview that we've brought today. Thank you.
Chair, I've been a councillor for 17 years, and my deprived area, what's based on this, hasn't changed with those residents. They are still struggling in some form of whatever they are doing, because that's where they are and that's where they stays. And we used to work more with third sector. It's no fault of yours. It's because of budgeting, whatever. But the work is going on. But we take cigarette smoking, for instance. We're taking something away. What are we giving back for them to get the motivation not to smoke? Don't smoke. They are going to smoke, but we have to offer something on the plate for them to reverse it. But my deprived area, if you go back in the Beck Hills, some part of Chapeltown, I'm sorry, health inequality is very poor.
Thank you for that comment, Councillor Taylor. Councillor Harris, did you want to come in?
If I may, Chair, and through you, if I could just put my cabinet hat down and put my ward hat on, from some anecdotal stories from my ward in Gipton Hare Hills. Actually, Public Health have done an incredible amount of brilliant work, and it's really difficult, Councillor Lay, to sort of say, well, what's the impact? But I can tell you as a ward councillor that Public Health have been in every meeting where we've had an off licence, and they've objected to it, and as a result of that, we've actually got about 15 less off licences in Gipton Hare Hills, and actually as a result of that, we've got less people on the streets drinking, and as a result of that, we've got parents and mothers going to school and to the local mosque, to the local church, without having to deal with gangs of people dealing with that antisocial behaviour. One of the things Public Health colleagues have done in my neck of the woods also is done a health assessment on the Roma community, which we all know have one of the most lowest health outcomes. And on the back of that, we're doing some really intense work in our local GP services with somebody from the Roma community, and that's because of Public Health doing that intervention work. So I just want to say thank you. And sometimes you can't sort of put that in a report, but it does have an impact. And yes, absolutely, health inequalities have got greater. There's a cost of living crisis as well that we've been dealing with, not to mention sort of the funding cuts that we've all had. Despite that, I do think colleagues, particularly in Public Health, and I don't say this because I was a Cabinet Member for Public Health, are extremely committed, work in our communities, and I just want to say thank you. And yes, we've got a lot of work to do, but the work you are doing is really making a difference. Thank you.
Thank you very much for those comments, Councillor Harris. So we're just coming to the end of this debate, and I think one of the things that stands out to me is there's lots going on, but it's also a lot to do, and there's loads of headwinds. It's a phrase, but in reality it means there are lots of challenges to making progress. But staying still doesn't sound like progress, even if it's the reality is that's doing well given the wider impact. So the recommendations for this report are just to note it, but I've made some notes on some things I think either we need to comment or action. So I'm just going to go through my thoughts, and if any members want to add to that, you can say so. So the first thing, I think we need to just pick up with Claire around how we can support her and Kara's Leeds engage with schools, anything we can do to maybe, if depending on what is asked for, maybe I can write a letter on behalf of the board. The second thing, something around no wrong doors, and I think Councillor Ritchie was very honest in the idea of have we asked these questions as school governors, and we're all corporate parents and lots of us are school governors, so I'm proposing that we write to all councillors around the no wrong doors policy, and sort of just a couple of questions they might want to ask as governors to just upskill all of us where we are school governors, which lots of us are. The third thing is on East Leeds Orbital, and I know it's Councillor Gibson's ward, but I think it affects much wider than just, it's not a ward issue, it's east of the city issue, which isn't my part of the city, but it's a quarter of the city. And so I think understanding what's been done there, 5,500 homes, is something I think is significant enough for scrutiny level. So I think we're going to ask Tim to come back with some written stuff about what actions he's going to take on that. And then the fourth thing I've written down is the public health grant. And I think we should write to Minister as a board saying we're still really disappointed about it. And I reflected on this. I wrote as chair with the last government and lamenting the fact that we haven't got enough public health grant. And so I think it's right, as a scrutiny board, we're meant to be acting non-politically, that we write to this government and say we're still not happy with the health grant we're getting and it needs to be better. So those are the and then the fifth thing I wrote, and I think and that was off Councillor Taylor's comments, was just a recommendation or an encouragement for the public health team to do more with and continue its focus on working with partners. So I think what you've said around whether it's primary care, aka GPs, or whether it's the police, the point is it's only going to work if we work with others. We don't have the power, in inverted commas, to do it just as the council. So those were my sort of thoughts and reflections. Councillor, if there's anything else specifically on actions, you can come in. So Councillor Bromley.
Yeah, my request is just that we bring back looking at some more work on the heat and Leeds thing and how we then incorporate that with all the different elements in a more multidisciplinary way.
Yeah, thank you. And that's particularly relevant given that the health of Leeds assessment that Victoria brought at the start of the year, was at the start of the year, earlier in the year, was about living in heat. And so that needs to be progress needs we need an update on progress anyway. So yes, happy with that when I get my words out. Good. Okay. I'm going to. Is anyone against any of those policies? I think that's the quicker way. Great. Okay. So we're going to move forwards on that basis. I'd like to thank everyone who's come for this item. We really appreciate it. It's a really important topic, and as a city, we're really committed, and you can see it's not just one side of the political spectrum that's into this. Like cutting inequality is really important, and so just real encouragement to keep doing what you're doing, and we really appreciate it. Just so everyone knows, we're going to have a 10-minute break now, so we're going to come back at 25 to 4 on that clock. And so if you're moving seats, please feel free to do that now, or have a comfort break. And I'll let you know a minute before we start again. Thank you. Okay, everyone, welcome back to the meeting. Thanks for rejoining, everyone. So we're going to move on to item 8 of the agenda, which is a really important item. But before we start that, we've got a new face at the table. So, Kate, can you introduce yourself? Thank you.
Hi, I'm Kate Simpson, Head of Commissioning for Older People.
Thank you very much. And Councillor Arif, I think you're going to introduce this paper.
Yes, I am, Chair. Thank you. So this report sets out our vision for home care commissioning. The home care market in Leeds is large and complex. The scale presents a number of challenges, not only for the council but also for providers and people who draw on our support. The Community Health and Wellbeing Service pilot has tested a new locality-based model in the west of the city. Under this approach, two of the providers were commissioned to deliver home care packages in the area, requiring a new approach to care planning, delivery and how staff are supported. The results of the pilot were encouraging, and we have seen a clear benefits for individuals, care workers and providers. These include closer coordination between individuals, providers and adult social care professionals, an enhanced hourly rate to cover gaps in care workers' run, new monitoring arrangements and positive figures in terms of achieving outcomes, a significant reduction in the number of double-handed care packages, quicker brokerage than the city's average, and a high job satisfaction for care workers. The Council is now proposing a rollout of this model citywide. We intend to do this in 2 carefully managed phases, ensuring continuity for residents and giving providers the time and support they need to adapt. Phase 1 will establish the foundations. We will run a tender process to ensure we have a strong pool of providers who meet the standards required for this model. Alongside this, we will offer training and support to help providers align their practice with this new approach. Phase 2 will involve selecting long-term locality providers from the pool, with opportunities for small and large businesses to grow. This will be a detailed and rigorous process, ensuring that the chosen providers can fully deliver the model and its ambitions. By moving to a locality model, we're supporting the Council's ambitions of ageing well and moving to a neighbourhood health model. This is a significant step forward for home care in our city. It builds on what we have learned, it strengthens our partnership with providers, and above all, it improves the experiences and outcomes of the people that we serve. Thank you, Chair.
Yeah, thank you, Councillor Arif. It's just to say that, we're really, really proud of the outcomes of the Community Health and Wellbeing Service. I've got the first draft of the final evaluation report, and it shows some really strong outcomes and work. The report sets out our plans to, go to tender in June, and then over 2 phases go towards a locality model. But that's not to say from April next year there won't be significant benefits and changes. We've got an opportunity to write a service specification focused on quality, performance monitoring, just strengthen it with a pool of providers and set the expectations and work with them towards when we're ready to go out for the second phase, to get large and small providers across the whole of the city delivering home care, probably around 2028, 2029. And for questions?
Great. So just a reminder, if this all seems very familiar, board members, we did have a briefing on this on the 19th of January, but obviously that was a briefing rather than a public meeting. If you look at the pack on page 95, paragraph 38, those were the points we made last time. But if you have other questions, comments, things you want to raise, this is your moment to indicate. My general take from the conversation we had on the 19th was we're broadly supportive of the 2-phased approach. Okay, so I'm going to bring in Councillor Blackburn, and if anyone else wants to comment, please indicate so. Thank you.
I noticed in the report, and I can't find it now, it said that there might be, in those areas like mine, where we've been part of the pilot, it might cause some sort of disruption when it goes out across the city. Are we going to try and make sure that that disruption is as little as possible to existing users?
Thank you, Councillor Brandman. Yes, it's because from April next year, the pilot area will no longer have exclusivity for the 2 providers who delivered the pilot, but there's no plans on moving any of the people they're currently supporting, and according to the new expected brokerage criteria, what we want to do is change it so that providers with runs in the area, supporting people in the area, will be prioritised to pick up new packages. So I expect the 2 providers to stay and continue in the area, but no plans to move anybody.
I'm happy with that, and as I said at the previous meeting, it seems to be working okay, so let's get on with it.
If I could come in, I mean, the alternative approach is to go out one stage, one full tender process, and that we know does exactly what you're describing, Councillor Blackburn. It does mean a lot of change for a lot of people, and we've taken that into consideration. Normally that's the route. It would be one massive procurement in one go, but we recognise that that is really disruptive to people who need services, to our local residents, and that's why we're taking this rather gradual 2-phased approach.
Unfortunately, I couldn't make the working group. So I just wanted just to say it's fantastic your use of the citizen panel, and just to confirm that that will be ongoing through the next 2 phases.
Thank you, yes. We use the citizen panel to set up and mobilise the pilot, but we will, now we know what we're doing to the timeline, we are going to go out and consult very widely with local people, partners and providers. So yeah, this is kind of the kick-off for me today with your support. Thank you.
Great. I can't see anyone else indicating. So the recommendations are: note the contents of the report and support the commissioning plan for 2-phase introduction of a full locality home care contract. I'm proposing that we accept both those recommendations. I can see nods around the room. So that was that's agreed. Thank you. Obviously, you've already talked to us about this back in January. I'm really positive. Anyone who is watching this at home, you can read the report and see why we are positive about it in your own time. So super. Thank you very much. We're going to move on to item 9, which is the work schedule. If members have any comments, please indicate. That I'm not looking up, so you'll have to wait a second. The thing I need to highlight is so the review of broader outcomes linked to the Learning Disability Partnership Board strategy. This is sadly needs to be moved until after the new municipal year. So we're proposing it stays on the agenda. Really important that we feed into the actual decisions of this strategy, and so that's what I've gone back to the team who've asked for it to be delayed. Are there any other comments on the work schedule? So I can't see anyone indicating. Yeah, Councillor Ritchie?
We were supposed to be setting up a working group around the strategy for deafblind services. Has that dropped off the agenda?
In terms of that, it's the intention is to commence it formally early in the new municipal year, but I will be sharing draft terms of reference so that this board can actually feed into what that review will entail. But the idea is that it will actually commence early in the new municipal year.
Thank you for that, Councillor. It's really important, and it's a really important work stream. Anything else? No? Okay. So thank you very much, everyone, for joining today. I feel like the main item was really important, and I appreciate it was engaged with from all sides and supported in that sense. So thanks, everyone. Have a lovely evening.